Since our founding in 1930, Borowski Insurance has stressed the importance of professional expertise and localized experience. Conveniently located in downtown Northampton for 91 years, the agency is co-owned by Robert Borowski and David Malik, who have more than 60 years of combined insurance experience. As an independent insurance agency, Borowski seeks to grow by providing our clients with the best insurance products and services available, while maintaining the highest standards of professional conduct, education, and commitment. Find out more at our website, borowskiinsurance.com.
This presentation has been approved by the American Nurses Association of Massachusetts, an accredited approver by the American Nurses Credentialing Center Commission on Accreditation. Successful completion is judged by writing your name in the chat located on your Zoom toolbar at the bottom of your screen and responding to the post survey within 7 to 10 days. Each participant will receive surveys via DocuSign by end of business today. There has been no conflict of interest identified for this presentation.
Good afternoon, and welcome to the 5th Annual AFC Summit, proudly hosted by Nonotuck Resource Associates and the statewide AFC Roundtables. This year marks the second year of the AFC Summit having gone virtual through the development of this webinar series. Although virtual, the mission of the AFC Summit remains to provide an opportunity for AFC provider agencies to learn from one another, to share information and resources through networking, and to continue the ongoing dialogue between organizations through our statewide AFC Roundtable groups. These groups will return on a regular meeting schedule beginning July 2021 in a virtual format. Today you will have two moderators, myself, Deb Schneer, and Carrie Parody, who will assist with Q&A. A few brief instructions to participants. All participants have entered today's webinar muted and with their cameras turned off. We ask, out of respect to your presenters, that you do not turn your cameras on or unmute unless directed by the moderators during the Q&A. Please submit your questions to the presenter through the chat located on your Zoom toolbar. The presenter will respond to your questions periodically throughout the presentation. Today's webinar will also include a poll of attendees. When prompted, please respond to the poll question and your answers will be shared with the group. Without further delay, we'd like to introduce today's presenter, Jeff Kielsen, Vice President of Strategic Planning for Advocates. Welcome, Jeff.
Hi, thank you. So before we get started, we're just going to do this quick poll so I can just get a sense on the level of knowledge of people around some of the mass health reform. Just log in whether you feel you have a lot of knowledge, some knowledge, or no knowledge. Okay, great. So a few of you feel you have a lot of knowledge, so hopefully this won't be too basic for you, because most people have said they have some knowledge, and a good 1/3 of you have said they have no knowledge. So we'll take it from there. And as was said, if you have any questions as I go through this, just put it in the chat, and we'll do the questions as I go through the presentation, and also leave time at the end as well. So in terms of just a framework, I think it'd be good to just take a little step back, because really a lot of the healthcare reform initiatives began 7, 8, 9 years ago, and have continued over the last few years. And basically the basic principles, both from the federal government as well as Massachusetts and state governments around the country, is the notion of really providing integrated, coordinated care across physical health, behavioral health, and long-term services and supports. And the basic notion was that if care was integrated and coordinated, across all the needs of someone, it would provide better care, improve outcomes, and primarily reduce the cost of healthcare by reducing emergency room use, hospitalizations, readmissions, and nursing home admissions. So that was the basic framework. If care was coordinated, we could reduce some of these costs and people could still get better care and better outcomes. Clearly, one of the concerns for those of us who provide long-term services and supports was that if those services became part of healthcare reform and undermanaged care, and if the physical health and behavioral health costs could not be reduced, then there was concerns that long-term services and supports would be, cut over time. To date, that has not happened. Massachusetts has been really thoughtful about this in some ways. And as we go through this, you'll see that the real total integration of long-term services and supports have really been delayed a little. So we'll touch upon that as we go through this. So the components in Massachusetts were or are the Senior Care Options Program, OneCare, I'll get into more detail in a minute, accountable care organizations, the LTSS and behavioral health community partners, managed care organizations, and the third-party administrator. So in some states, it's a lot more simple. For example, in Kansas, there's 3 managed care companies who do everything. Massachusetts has tried to be very thoughtful about this in really developing these different components. So the Senior Care Options Program, which many of you may be aware of, has been, in Massachusetts for, believe more than a decade. It was kind of the first real managed care initiative. It's for people over 65, people on Medicaid and Medicare, although there are a small number of people in Massachusetts that are just on Medicaid over the age of 65. And right now, the plans are Senior Whole Health, Commonwealth Care Alliance, United Healthcare, Navicare, which is Fallon, Tufts, and Boston Medical Center. Basically the concept here is those managed care companies have responsibility for managing, all the services across Medicaid and Medicare, including, the state plan, long-term services and supports. And some of you or all of you might have had contact with one of these plans because they would be responsible for paying for adult family care for their members. There's about 120,000 people in Massachusetts eligible for the Senior Care Options Program. The second, which is newer, it goes back maybe 5, 6, 7 years, is the OneCare program. The OneCare is for people 21 to 64. Again, people on Medicaid and Medicare. People on any home and community-based waiver services are not eligible to enroll. I mean, this is an important point. So if you're receiving, for example, any waiver services from DDS, then you're not eligible to enroll in OneCare. So you might be getting a DDS-funded day program, and you might get also AFC, but if you're in a waiver service, you're not eligible to enroll in OneCare. This is one area that has been, a question for a number of years whether people on the waiver would be allowed to enroll for their non-waiver services, or if the waiver services, like in other states, would become part of OneCare. We'll talk more about this later as well, but at this point, there are no plans to allow people on the waiver to enroll, and there's certainly no plans to in terms of with the Department of Mental Health, where their ACCS program, the Adult Community Clinical Services, that is funded by DMH, primarily provides residential supports. People who are enrolled in the ACCS program can enroll in OneCare, but their ACCS services are still funded by DMH. Whereas if you have waiver services from DDS, you're not allowed to enroll at all. So that's kind of a difference that I wanted to mention, because that sometimes creates confusion. Right now, there's currently 2 plans, Commonwealth Care Alliance and Tufts. You know, the overwhelming majority of people who want care are in Commonwealth Care Alliance. The Tufts program is fairly small. Originally there were 6 plans who got approved. 4 of the plans decided, or 3 of the plans initially decided not to do OneCare because they felt they could not financially make it work. One plan, Fallon, then dropped out after they were providing a OneCare program because they were simply losing, too much money. So that brought it down to 2 plans. And as I said, there's really not been much competition because most people are enrolled in Commonwealth Care Alliance. The state did put out another RFP to expand OneCare because they really wanted more plans to be able to expand the OneCare availability across the Commonwealth. And again, United responded, as well as Senior Whole Health, Fallon, and Boston Medical Center. Part of that expansion of OneCare is they wanted to align the providers of SCO and the providers of OneCare. Even though they're 2 separate programs, they wanted to align who is providing those plans and create a little more synergy across the plans. So they did the bidding. Even though Fallon and Boston Medical Center were initially approved, they both decided they really could not make it work, so they withdrew before final the implementation. And United Healthcare remained interested. Because of COVID, as well as perhaps other issues, originally the expansion was going to happen in January 2021, and now it was delayed until January 2022. So in January 2022, unless something changes again, at this point it doesn't look like it will, United Healthcare will become the 3rd OneCare plan. And I'm sure you could appreciate when there's 3 plans and the notion is really the priority to expand enrollment in OneCare, there'll be a lot more activity in terms of enrolling people, which I'll get into in a minute. There also, frankly, is some concerns because United is so large that whether that would, become the lead plan, and some concerns that, because they're a national for-profit company, that might impact services. But I think obviously we'll have to see. I personally really welcome more competition. It gives people more choice and more opportunities potentially. So as with the SCO program, OneCare, the plans are managed care companies. They're accountable for the delivery and management of all covered medical, behavioral health, and LTSS services for their enrollees. And as I said earlier, with the exception that DMH still funds the ACCS programs. So if you're enrolled in OneCare, you could also get the DMH services and have both care coordination from the OneCare as well as from the provider who provides those ACCS services. The plans authorize and provide the full array of Medicare and Medicaid services. Something to really note that in the past, people have been passively enrolled in OneCare, so they would get, something from Mass Health that said they're being passively enrolled in, whichever plan, and they have the opportunity to either disenroll or not accept the passive enrollment or change plans. There was a hold around passive enrollment now, I believe, until United gets up and going, and then I could see passive enrollment, really, taking hold again and increasing. So people, each of you, as well as, in terms of support you give families or individuals that you work with, I think you want them to be aware, if they do not receive waiver services, to watch out potentially for correspondence from Mass Health about passive enrollment, particularly as we get closer to, the January 2022. There are some benefits of OneCare in terms of lower co-pays. OneCare has greater ability to fund services that straight Medicare and Medicaid do not fund. Non-medical transportation, for example. There's increased, or there's dental coverage. So there's broader services that people could access through OneCare, which is one of the incentives in enrolling. But people should really research both the pro and the cons, because as managed care companies, there's a more limited network of providers than you would have if you were just straight Medicare or Medicaid. So if you have a Medicare card and a Medicaid card, you could access a broader range of healthcare professionals than potentially if you were in one of the OneCare plans. And I know a lot of people who have not enrolled in OneCare because they would, kind of lose the healthcare professionals they've had for many years, and others who have enrolled because they like the more intense care coordination and the other benefits. So this really, I just wanted to highlight this as something that people should really look at very carefully, not unlike some of us might do if we have more than one healthcare option through where we work, to see what works best for, for us.
Yeah, before you move on, can I ask you just to explain what passive enrollment means?
Oh, yeah, sure. Thank you. So passive enrollment, rather than having someone affirmatively say, I've done my research and I want to enroll in, let's say, Commonwealth Care Alliance or Tufts, or soon to be United, or making the decision, I don't want to do anything, it's totally on them to make that decision. Passive enrollment is if you have not made a decision, Mass Health could passively enroll you in one of the plans. So, for example, if they saw that you saw a particular, physician, and that practice happens to be part of the network of Tufts, they might then passively enroll you in Tufts. So you'd get a letter saying that you're being enrolled in Tufts. So that's what passive enrollment is. Rather than you having to affirmatively do something, you would be enrolled through kind of what Mass Health does. Now, within that, you have a certain amount of time, as I said, to withdraw or to tell Mass Health you're not interested. But you have to watch out for that, for that letter. There is some structure where you could say that you don't want to be passively enrolled, but at this point, you just want to watch out for that. Sometimes a family, an individual may get a letter, may not look at it. I had a situation where a family member then saw the letter weeks later, and then said they were not, not interested in enrolling. So that's what passive enrollment. Did that answer the question, or?
Yes, I think it did, and I think what we tend to see for people who are passively enrolled as providers, we may not know until there's a billing issue.
That's right. Right. What sometimes happens is someone's enrolled, some of you might have experienced this, you go to bill Mass Health, and Mass Health says, well, we know the person's no longer covered by Mass Health, they're covered by TOPS or CCA. And then you kind of track it down from there. So I think at this point, kind of my recommendation is, to the extent there's communication that you send out to people you support through AFC, particularly as it gets closer to January, you may want to get something out there that talks about the expansion of OneCare, and for those people who are not on the waiver, to kind of watch out for that. Now, of course, there are a lot of people who don't have a clue whether they're on the waiver or not, and that's another education that needs to be done with people in AFC. So you just may want to think about, as individual agencies, what kind of education you want to try to do with people in AFC around, particularly around OneCare. Now, if you're in OneCare and turning 65, you would have an option to stay in OneCare past your 61st birthday, or transition to the SCO program. And while there's a lot of similarities, there are some differences. So, you do want to do research at that point as well. Even though, Tufts, for example, provides both, SCO and OneCare, it's two different, plans, two different quote unquote products. So they're not necessarily identical. So you do want, if you know anyone who is approaching their 65th birthday, you may want to either help them or advise them to look at both, the SCO programs and OneCare. And of course, with SCO right now, there's other plans that provide SCO. So, you might see a benefit, for example, of the Senior Whole Health Program, even if you're enrolled right now in the TOPS OneCare program. So you do have that option when you're turned 65. This is an interesting chart. I mean, it's obviously a little outdated, but it just reflects on the OneCare side how, if you have complex behavioral health needs, or certainly if you're someone with a developmental or an intellectual disability, the percent of the enrollees or potential enrollees are far less than the actual cost. So if you have an intellectual or developmental disability, the costs in OneCare exceed, the average cost of other members. And this, this highlights, the concern in moving into OneCare, that it might impact, services as well. I think this is another reason why the advocacy to not have people on the waiver enroll in OneCare is reflective of the concerns about people moving into more managed care situation.
A couple of questions.
Yeah.
So one is, can a member disenroll from the program and just choose to just have their straight Mass Health and Medicare, and when can they do that?
Yeah, so good question. Yes, people can disenroll. If my memory, this has changed. When OneCare started, you really could disenroll on a monthly basis. I believe, Mass Health has now put in place you can disenroll every year. Now, you could disenroll more frequently if there was a significant reason why you wanted to disenroll. I think that's accurate, but it may not be totally accurate. But I could double check that, and if I gave you some misinformation, we could let you know. But the bottom line is, yes, you can disenroll. It's a question of whether you could disenroll annually or more frequently. But I know if there's a good reason why, Mass Health could approve disenrollment, more frequent than we're having to wait, a year to disenroll. But that's one of the reasons why, if you get passively enrolled, you do have, I believe it's 60 days, maybe 90 days to disenroll. So you want to give a lot of thought to that. But yes, people disenroll in OneCare all the time. I mean, not a high percentage, but it does indicate, either some level of dissatisfaction. I think people may find after the fact that they're losing some of their specialists, as possibly their primary care physician. So they really want to go back and have more flexibility on their healthcare side, and are not willing to compromise that for some of the increased coverage they would get through, through OneCare.
And then there was another question just about can you have OneCare and AFC?
Yes, so if you're not on the waiver and you do enroll in OneCare, then OneCare plans are responsible to fund all state plan services, of which AFC is one of them. So what would shift is, rather than getting paid by Mass Health, you would get paid by the OneCare plan, whether it's Commonwealth Care or Tufts or soon to be United. So similarly with the SCOPE program, the OneCare plan, the SCOPE plans pay AFC directly. OneCare is the same. They are responsible for paying for all your medical, all your behavioral health, and all the state plan Mass Health services. As I said, there's some concerns that the OneCare plans, in terms of, because they do the prior approvals, they may, kind of reject people or make it harder. I think part of that is, dealing with a managed care company, which some of you might have experienced directly. But I have not seen any data that indicates a reduction of the commitment to AFC, as well as to the PCA program, the sister program to the AFC. But the OneCare plans are directly responsible for approving that and paying for it.
And do the agencies need to be contracted with the OneCare programs? Is that correct?
Yes. So, the agencies do have to have contracts with the OneCare in order for the OneCare to pay them. The only exception, which I should have mentioned earlier, there is a continuity of care, where the OneCare plans have to pay for a period of time, the current services. So let's say someone, sees a specialist, and that specialist is not part of the OneCare network. For a period of time, OneCare has to pay that specialist through an out-of-network agreement, and before they maybe transition the person to, to another physician. Similarly with AFC, they should not stop funding, even if you don't have a contract, for a short period of time. But any of you who want to work, if you're not already, who want to work with one of the OneCare plans, should work on having a contract with them. I mean, frankly, there were some concerns, and still are, that as more and more gets under managed care, that the managed care companies are not necessarily going to want to work with as many providers as Mass Health works with, be it AFC or anyone else. So there are some concerns that, they may want a smaller network to work with. I have not heard that has happened yet, but just to put in the back of your minds. Were there any other questions regarding OneCare? Is that?
I think that's it for right now.
Okay, all right, good.
Thank you.
So the other piece is the accountable care organizations, which people might have heard about. So this is a little different than the SCOA OneCare. The concepts are basically the same, that there's been unsustainable growth in the Mass Health budget over time. That the feeling is that the current fee-for-service model has been very fragmented. So the concept of accountable care organizations also is to try to stop the percentage of growth in Mass Health, to improve quality and access, also by reducing avoidable emergency department use and hospital admissions. So the first year of the ACOs, which is at the end now of the 5-year demonstration, was to integrate physical health and behavioral health under these accountable care organizations. And there are, I think, about 18 across the state. Steward Healthcare, Mass General, Atrius, just a lot of different accountable care organizations. Originally in year 3, the state plan long-term services, including AFC and DAHAB, were then going to be integrated in. That has not happened yet. And at this point, there are no plans to have that happen. Partially is because the accountable care organizations really did not have a really good concept of what long-term services and supports are, because they're primarily hospitals and primary care practices. And so that's why it was going to be delayed till year 3. And now it's really put on hold. So the ACOs are basically responsible for the physical health and behavioral health. There was also some discussion in the future to include waiver services, but that's on hold at this point as well. And there's no thinking to do that. So both in terms of the state plan services, LTSS services, and the waiver. So unlike the SCO and OneCare, the target population here is Mass Health only. So these are people that only have Mass Health. So it excludes those that are on Medicare. They would fall under OneCare or the SCO. And if Mass Health is a secondary payer, because you're covered under your, for example, parents' private insurance, and Mass Health is a secondary payer, you're also excluded from the ACOs. Now, people on the waiver will be enrolled in the ACOs, but again, the waiver services will be directly by DDS or other state agencies. So it gets a little tricky here. So if you're Medicaid only, and Medicaid is the sole insurer, then you would be enrolled in ACOs, and I'll get to that in a second. But your waiver services and LTSS services will be funded by the state agency or Medicaid directly. So you might have people in the AFC program, you might not even know that they're enrolled in an ACO because you're still dealing with the Mass Health process in terms of AFC. Because the ACOs are right now physical and behavioral health. So the components of the ACOs are the ACOs themselves, either the hospital group or the primary care group. There's community partners, LTSS and behavioral health, which I'll get a little more information in a minute. And with some of the accountable care organizations, they're also affiliated with managed care organizations. So it's a partnership between a managed care company and the ACO. And the federal government has provided a lot of money to help build the infrastructure for all of this. The reason initially why it was important to mention that some ACOs, in fact, most of the ACOs, are connected with MCOs is one of the reasons for that connection is ACOs are not used to paying other providers. So they link up with an MCO who does the payments to the network of providers. The other reason that was important is the original plan of having the long-term services and supports integrated in with ACOs. That was only going to happen if the ACO was in partnership initially with an MCO. But now that's not as relevant because that's been put on hold. So that's the accountable care organizations. As I said, the ACOs are groups of doctors, hospitals, and other healthcare providers come together to give coordinated care. Provider-led organizations are responsible for the total cost of care, medical and behavioral, but not the LTSS services. I should have taken out until at least year 3 because it's now past year 3 and it's not happening. You know, the ACOs provide primary care, comprehensive assessments, care coordination, disease management, etc. Some of you might be working with ACOs just to help with your members access healthcare. And the ACOs are required to contract with community partners to do some of the care coordination. And this focus was on the 1.2 million Mass Health members that basically have been fee-for-service, where Mass Health is the sole provider. So it was a huge initiative. And how you get assigned to an ACO is based on where your primary care is linked. So a lot of primary care practices are part of an ACO, and then you automatically get assigned to that ACO if your primary care is part of that ACO. So if you see a primary care from Atrius, you're automatically assigned to their ACO. And so in that essence, it's kind of blind to you. You may not even realize now you're part of a quote unquote ACO. But that's how the ACO assignment is driven by your primary care. I'll get to in a minute if your primary care is not part of an ACO. But every one of these 1.2 million people are assigned to an ACO. So the ACOs, you know, have this relationship with community partners. There's community partners on the behavioral health side and on the LTSS side. They participate in the interdisciplinary care teams. They provide care coordination. They're certified by Mass Health. And right now, they're funded directly by Mass Health. So you're not as much impacted as an AFC provider by all of this, as I said, because Mass Health still is funding directly the LTSS services. But at some point, if the LTSS services become part of the ACO network, then there might be the community partners providing some of the care coordination to those members. And it would be the MCOs affiliated with the ACOs who then make the determination around prior approval. But right now, that is not something I don't think to be concerned about, at least in the near future. Some of you might have had some contact with, you know, LTSS CPs, and in order to be qualified, you know, they had to have had, you know, experience working with people with LTSS and BH needs in a wide variety of situations. Also people with brain injuries, people with physical disabilities, people with intellectual and developmental disabilities. The ACOs begin at age 3, so there are a lot of children who are assigned to an LTSS community partner. You know, and these are some of the care, you know, the core functions around the care planning and care coordination. You know, as I mentioned, you know, the federal government provided, you know, in Massachusetts' case, $1.8 billion over the 5 years to really develop the infrastructure for these ACOs. You know, with startup costs, you know, in a wide variety of ways. for the ACOs, for the community partners, and to help with statewide infrastructure around workforce development in multiple different ways. This was a huge initiative, as you can imagine, with 1.2 million people. I should have mentioned the OneCare population is also around 125,000. So you see the bulk of the people on Mass Health in Massachusetts are Mass Health being the sole payer. The rest have the combined Medicare or, private insurance. So the district money runs out. I think next year might be the last year, and it'll be interesting to see how this, progresses. So again, the primary focus of the ACOs for people you support is just coordination around their healthcare and behavioral health services. You might have had some family members or individuals complaining to you about some level of frustration with their ACO. So from my perspective, it's good to be aware of this in case you could help people navigate the system. I think there are about 18 ACOs across the state. So then the final real component, if you looked at everyone on Mass Health, is just straight managed care organizations. So for people who are Medicaid only, but are seeing a primary care physician who's not enrolled in an ACO, then they could enroll in one of two managed care companies, Boston Medical Center and Tufts. So if you looked at this as a total framework, you'd have, for people on Medicare and Medicaid, the option of the SCO if you're over 65, the OneCare if you're 21 to 64, or keeping your Medicaid and Medicare fee-for-service cards. If you are on a waiver, you don't have that choice. You're just a fee-for-service through Medicaid and Medicare. If you're Medicaid only, you go to an ACO if your primary care physician is part of an ACO, and if not, then you become part of one of the two managed care organizations. And still, for a small number of people, you could just keep your fee-for-service. But clearly, you get the flavor that Mass Health really is moving as aggressively as they can away from straight fee-for-service, for the reasons that I had mentioned at the outset, that fee-for-service does not really provide that care coordination. It's siloed, and it's very hard to get control over the cost of care if basically people are going wherever they want with the lack of coordination. You might have had really varied experiences on how things are working, but that's the basic concept. So there's a very small number of people that are straight Medicaid that are on one of the two MCOs. The third-party administrator, I'm sure a lot of you have had experience with. So they basically, Mass Health is delegated to them, some Mass Health functions in terms of oversight and prior approval for, the state plan LTSS services. So if you are getting funded directly by Mass Health, then the third-party administrator, is delegated that responsibility, and that's Optum. I mean, ironically, Optum is very quickly becoming a large primary care practice in Massachusetts, as they've taken over some primary care. But so you might have heard about Optum in terms of primary care, because they have purchased, for example, Reliant Medical Group, and some of you might have some people who get their primary care through Reliant. if you're in a MCO, you know, through OneCare or the SCO, OneCare handles those responsibilities. But if AFC is funded directly by Mass Health, then the third-party administrator, you know, handles that. And which is why, as an AFC provider, you want to obviously maintain, you know, your certification with Mass Health, but you also want to have those relationships with the managed care companies because they, you know, fund directly AFC for their members. You know, the last thing I want to highlight before I get into looking ahead a little is the My Ombudsman program. I'm not sure how many of you have heard about this, but particularly with you know, everything that has happened around you know, the healthcare reform and, you know, with OneCare expansion and, you know, things to come, Mass Health has put in place this My Ombudsman program, which is independent and available to any Mass Health member enrolled in a Mass Health plan, such as an ACO or OneCare. My Ombudsman initially was focused in on OneCare members, and it's now expanded if you're enrolled in any Mass Health plan. So they can answer questions and help members access benefits and services. You know, it's their role is a little different than the Shine, in case some of you might have had some contact with the Shine, which helps people also understand what are their options. But the difference in My Ombudsman is it also gives information about Mass Health plan benefits and rights. It listens to members' concerns and try to help address problems. So while Shine may do some counseling on what might be better options around the Mass Health possibilities, My Ombudsman is there to hear if there's concerns. So if you're enrolled in a OneCare program and you know you have a concern that, let's say, they're not approving, you know, the AFC, then this is an avenue that people could go to. So they listen to members' concerns, helps address problems. They try to facilitate communication between the member, the providers, and their health plans. And they also explain how to file a grievance or an appeal, whereas a grievance is a complaint and an appeal is a formal way to request Mass Health change a decision they made about a Mass Health plan made around a member's benefits or services. So this is important to you know, have their contact information you know, at hand in case, you know, you could help. Someone has a concern and you want to help them facilitate, you know, kind of bringing it to someone's attention, you know, through the My Ombudsman program. It's not directly operated by Mass Health. It's the Disability Policy Consortium who operates My Ombudsman. So they have, you know, some independence from Mass Health, and their focus is helping resolve complaints. You know, so that's their contact information. So as we're looking ahead, I just kind of wanted to reiterate a couple of things, you know, maybe before we kind of open it up to, you know, questions or comments. Again, there's no current plan to have the LTSS programs part of the total cost of care for the ACOs and MCOs. There's no current plans to have people receiving waiver services eligible to enroll in OneCare, and no current plans to have any plan responsible for waiver services. So within those three things, I think a lot of concerns that many people have had as this kind of was evolving over the years have at least been either put to bed or put on hold. As an AFC provider, it still, you know, leaves, you know, a lot of complexities in working with different OneCare plans or different SCOs and Mass Health directly and the third-party administrator. But I'm sure you could appreciate if the LTSS programs were under the ACOs, it would make things, I think, far more challenging for all of us. Or if people on the waiver were eligible to enroll in OneCare, a lot more people you're supporting would be part of the OneCare program, and you'd be relying on them to get reimbursement. Because a lot of people in AFC also receive waiver services. The other thing I wanted to note, particularly, I think most relevant for OneCare, is as OneCare expands, because frankly, Mass Health wouldn't be adding a third plan, and United would not be getting into it if there wasn't the intent of having a lot more people enrolled in OneCare. The plans might be looking at different ways to pay providers other than the traditional fee-for-service that Mass Health pays. It's just something to be aware of, to put in the back of your mind, that this might be, might come up. It also might be to your advantage if you're working with one particular plan, to try to negotiate perhaps a more, a different methodology to get reimbursed, more like a payment for a certain number of individuals, where you might have some flexibility on how to utilize the funds a little differently. So as you're thinking ahead, over the next year or two, it might be something to put in the back of your mind. So that, in a quick nutshell, is kind of where things stand today. A little different from what the plans were a couple of years ago. And as we're looking ahead, I think it's a good indication, particularly around the LTSS services, that Mass Health wanted to be very thoughtful about this and not move things more quickly than people were ready to manage them, which could have caused a lot of disruption in the system. Some of you who might have been around a few years ago might remember some of the conversations where there was a lot of concerns about AFC getting under the ACOs, and concerns that the ACOs didn't really understand the AFC program. So, this either temporary or permanent delay, was really helpful and great to see, and reflective, I think, of the complexity of the work that you all do. So why don't I stop there and open it up to questions, comments, concerns, etc.
Yeah, Jeff, so we had a couple of questions. How can people find out if someone is on the waiver program?
So, great question. So so one way is simply to email or call or have the family call their service coordinator at DDS if they have one. Presumably most of the people that you support would be on a DDS waiver. So that's one way to do it. The other way, if well, you could assume if people are in a DDS funded residential service or a DDS funded day program that they're on the waiver. But that's one way, just to contact the DDS service coordinator. The other way, if for some reason that does not work out, you could probably email my Ombudsman, and they might be able to check pretty quickly in terms of the Mass Health system. So those are a couple of different ways to do that.
Okay. And then there was, how can a provider agency contract with a OneCare if they haven't done so already?
Okay. So each of the OneCare plans have a provider, they probably call it a little differently, a provider relations, unit or, some unit that negotiates the contracts with agencies. So you could either go on their respective websites and, find the contact information. I mean, if it would be helpful, and if there's a vehicle, I could, send that information maybe to Nanatak, and we could send it out in addition to the slides.
Sure.
Does that make sense?
Yeah, that would be, I think, very helpful.
Okay.
And then regarding the My Ombudsman program, will they assist with SCOs as well as ACOs and OneCare?
As far as I know, yes.
Yes.
I think it's any mass health plan.
Okay. And there was a question that says, what issues will Ombudsman work with Guardian or members on?
So I'll give you a couple of examples. One, for example, I'll give you my personal example. My niece, who was assigned to an ACO because her current plan was no longer an option under Mass Health, and that ACO didn't really have. They were going to disrupt all of her services because that ACO didn't have relationships with any of her healthcare professionals. So my ombudsman helped kind of work through that system. They get calls from members who have had services denied by their OneCare plan. So they get a call and say, this particular specialist was not approved, or I wasn't, approved for some alternative therapy. So my ombudsman helps facilitate the conversation. They can't tell a plan what to do, but they could really work and negotiate, particularly if the plan is doing something that that violates their contract. So, it's a combination of all the above. The plans, OneCare plans do provide some non-medical transportation, as I said. So, someone may call my ombudsman if that was not approved. And just for them to research, why was my transportation to a social group not approved by OneCare? Or if the transportation to the medical appointment never showed up 3 times straight, and the member wasn't getting any satisfaction from the OneCare plan. Or in the AFC case, AFC was denied. And you never got a reason why, or you got a reason that made no sense to you. So it's any, examples, like that. And as I said, if it seems to warrant a formal appeal, then they would help, kind of through that process.
So,
In all honesty, my ombudsman has not been used very much. I think part of it is the word is not out that they exist, which is why I wanted to add it.
yeah, well, Jeff, I'm wondering, and because I know that this is an issue for lots of different agencies, and that is the prior approvals not being approved or changed. Is that a situation where they might want to contact my ombudsman, where in the past, say they had been approved for level 2 services, and now CCA or Self-Unify, they're saying nope, they aren't.
Yes, I would definitely do that. As long as they fall under, one of the mass health plans like OneCare, ACOs, and I think SCOs. Yeah. I mean, there's only so much, obviously there's only so far you could get with the plan directly. And if you're not satisfied with that, then my ombudsman will be the logical place to go.
I think that that's a great resource that folks maybe don't know about.
Right. No, it's used very infrequently. And every time we discuss it, I ask, what are they doing to get the word out? So the people at Mass Health who basically, work with my ombudsman or supervise them, or, I said to them, I was doing this presentation and they said they would welcome me, kind of helping getting the word out around the program. And if the requests go up following this, we'll see if they react. But I would definitely kind of use them. I can't guarantee success, but I think it's an avenue that you should definitely explore without question.
Great. We don't have any other questions right now, or not that anyone has put in the chat. I didn't know if people wanted to maybe raise hands. We can unmute you, or please put any other additional questions in the chat.
Yeah, I went through a lot of detail very quickly.
Yeah, I think that the acronyms can get a little confusing at times. Donna, we are recording this presentation, so it will be made available in the future.
Yeah, I guess I would just reiterate or emphasize more that as all of this plays out, because a lot of you probably would only know if there's a problem with, one of, someone that you support through AFC, if they bring it up. But I really think it's a good idea to try to educate people, either as the OneCare looks to expand, to maybe know before next December or so, or this coming December, whether or not they're on a waiver service, and if they're not, to keep pay attention to as OneCare is evolving. So they're not caught short and they're thoughtful about it. Because as I said, OneCare could be advantageous to people. And to whatever extent any of you want to play a role in helping to educate, you should really give that some thought. The ACOs has been pretty straightforward around, the primary care physician. So it only becomes an issue if they're going to manage the AFC, which is not going to happen. But particularly for OneCare, you want to pay close attention to, to that. As I said, a lot of the fears that people had 3 years ago have not come to fruition because of these delays in putting AFC under some of these programs. But, you just want to be aware of them.
Now, can I'm assuming provider agency, can we utilize the ombudsman on behalf of our members?
Yeah, that's a great question. I mean, I would contact them. I mean, I don't know, frankly, what the reaction would be. If they may say, look, you should have the person contact us directly, or you may say, look, the person, for a variety of reasons, doesn't feel comfortable or cannot or whatever, so we're doing it on their behalf. They may ask, maybe they may want release of information form signed, but I would definitely call them. And see what they say.
So Jeff, another question about another OneCare agency. What if the agency, the OneCare agency, refuses to contract with their small AFC agency and the member was passively enrolled?
So, so I think there's a couple of things to try to do. Mass Health has not mandated, I should have said it. So each of these plans, when they, when they get approved, have to have, a network available, right? But short of having a network available, Mass Health is not mandating to any of the plans you have to contract with, 50 AFC providers, let's say. They would say you have to have relationships with enough AFC providers that you're providing that service in your approved area. All of this is by, geography. So, the plans don't have to be statewide. So they're not saying to a OneCare plan, you have to contract with 50 AFC providers. The plan may contract with 5, and that might give them an adequate network. So quote unquote network advocacy is tricky. Now, that being said, if you're providing AFC to someone who gets enrolled in OneCare, passively enrolled, the person is left with a very difficult decision. They could either disenroll because AFC is their number one priority. But if they feel that the plan offers them better behavioral health or physical health services, then they got to balance all of that out. So one option, they could disenroll. And they could say to the plan, look, I want you to contract with agency ABC for my AFC. And if you're not willing to do that, I'm going to disenroll. Now, the OneCare plan may very well be open to having a one-person agreement, because they're paying you the same rate they would pay any AFC provider, because the rates are standardized, obviously. So from a OneCare plan perspective, it's not additional money. Different than from a healthcare perspective. If I wanted to have surgery at UMass and my OneCare plan had a contract with St. Vincent's, OneCare may say, no, you have to go to St. Vincent's because the same surgery is 80% higher at UMass than it is at St. Vincent's. So there's some financial push for a OneCare plan not to approve, an out-of-network surgery, as an example. With AFC, it's not that financial incentive, that works against you. So the individual or the family could be your advocate, saying, look, I want you to contract with blah, blah, blah. And you could advocate within the OneCare plan and keep pushing them to contract with you. Short of that, I don't think there's much that Mass Health would do around, resolving that in terms of a contract. But my ombudsman might be able to facilitate an agreement around, one person at a time. I think the other thing is for you to think about as an agency is what makes your program work well, and what are the kinds of things that you would say to a OneCare plan. I mean, obviously I'm making this up, but if you feel you'd really do a good job working with the AFC, the family, in helping them support their loved ones, so the use of emergency rooms are less than maybe some other provider, something that could trigger some interest in the OneCare plan. If you're working with people with some, kind of unique needs or, certain kind of language capabilities that you have. So one thing is to think about what you as an agency, how you would sell yourselves to a OneCare plan if you wanted to grow that way. But leaving that aside, I think it's trying to get an agreement around one person And as I said, perhaps my ombudsman could be helpful. I wish I could say more, but I think it really becomes, the OneCare decision. Now, it could be that, particularly when there's 3 plans, that, you might contract with one and not the other 2, and your member might be fine with going to the one that contracts with you because they're getting some of the benefits of OneCare and, some of the other healthcare professionals they see might be part of both plans or might not be an issue.
Jeff, do you happen to know, I know that there used to be, and I think COVID threw things off, but there were these passive enrollment and almost like times that they would be coming out. Is there some sort of schedule?
Yes, I believe the last time I talked to Mass Health a few weeks ago in preparation for this, they were going to do one last passive enrollment in OneCare in April last month, and then hold off until the OneCare 2.0 got started with United in January. Why don't I, when I check on the maybe who you could call in terms of contracting with OneCare, why don't I find out what their plan is for the schedule for passive enrollment?
I think that would be helpful. I know in the past when we knew it was coming, it was something we would give families a heads up on to watch for something, because
Right.
we knew.
Yeah, no, that's a great question. I'm glad yeah, that makes sense. Yeah, no, it was never done willy-nilly. There was always a schedule when they would do passive enrollment. And I'll see what they're thinking as they're looking to expand OneCare in January. But as I said, the last time I talked to them, they said there would not be passive enrollment now until the expansion.
Any other questions? There's nothing else in the chat right now, but if anybody had any other questions, if you want to raise hands or anything, you could.
Jeff, we'll give folks another minute or so to add in any last minute questions that they may have for you. We're certainly happy to hear that you're willing to share your slides, and this recording will become available to folks on the AFC Summit website in the future.
And hopefully this was helpful. And certainly if other questions come up as you're hearing things, it is fine if you want to shoot me an email.
Sure, we'll make sure that we share your email address with folks too. It's right here on the cover page of Jeff's presentation as well. Without any additional questions for today, Jeff, we really wanted to thank you for once again presenting at the AFC Summit. We're always very lucky to have you. We'd also like to thank today's sponsor, Borowski Insurance, and we hope to see many of you back for tomorrow morning's webinar, which is Caring for Caregivers, Checking In and Creating Community with Janelle Robinson, Wellness Coordinator for Nonotuck. Thank you again, Jeff. Thanks, everybody.
Great, thanks. Have a great day, everybody. Bye-bye.
Thank you, Jeff.
Bye.